Over the past few months, I've been getting a lot of emails, comments under videos that all sound like some version of the same question. Christopher, everyone keeps telling me Medicare patients are about to get $50 GLP-1 medications. But when I go to the pharmacy, I cannot even use the savings card. What's going on? And honestly, that confusion makes complete sense. There was an announcement made in Washington late last year that got picked up, repeated, and shared thousands of times. We discussed it here, and every time it got shared, one important piece of context got left out of it. So in this video, I'm going to give you the full picture, where the $50 number actually comes from, what the government has announced, and what it has not. Why you still cannot use savings cards today, what your actual options are right now, and what has to happen before any of this changes. I want to be straight with you from the very start. If you are on Medicare right now and trying to access GLP-1s, this situation is urgent. The costs are real, the barriers are real, and the gap between what people are hearing online and what they are experiencing at the pharmacy is causing real harm. Welcome to the Downsized. My name is Christopher Durham, and along with my wife Lorraine, I have been on this adventure since September of 2023. Together, we've lost more than 150 pounds using GLP-1s, and like many of you, we have had to figure out what access to treatment actually looks like. Not in a press release, but at the pharmacy counter and on the receiving end of a bill that takes your breath away. Before we go any further, Lorraine and I are not doctors, and nothing in this video is medical advice. We are patient sharing what we have learned. If you are considering treatment, please work with your healthcare provider. And if you appreciate honest, practical conversations about GLP-1s without hype or shortcuts, please take a moment to like this video and subscribe. We publish new videos every day focused on GLP-1 medications, Zepbound, Mounjaro, Wegovy, semaglutide, tirzepatide, and all the new ones coming. Obesity science and helping people navigate treatment in the real world. So let's talk about the reality today. Today is Sunday, March 8th, 2026. The first thing you need to know is this. Right now, as of today, there are no $50 per month Zepbound or Wegovy prescriptions available through Medicare for the treatment of obesity. If you are on Medicare and your doctor prescribes one of these medications specifically to treat obesity, Medicare generally does not cover it. And because of federal law, you cannot use the manufacturer savings cards that many people with commercial insurance rely on. That combination creates a gap that we hear about from people every single week. It's not fair. You finally find a treatment that's working. You're losing weight, your health markers are improving, your doctor wants to keep you on it, and then you age up, you move on to Medicare, and the financial pathway to stay on treatment disappears almost overnight. I want to stay with that for a moment because it is not an abstract policy problem. We have heard from people who are months into treatment, years into treatment, who finally are feeling like themselves again. And then they had to stop because the cost became completely out of reach. Not because they chose to stop, but because the system left them no viable path to continue. In some cases, people are paying more than $1,000 a month. Now, I know you say that's crazy. Again, they can't use the cards and they want the pens. So yeah, there are compounding options. There are all kinds of things out there. But if you want to stay on branded medication, if you want to use the pens, the list price today is $1,000. We'll talk about more why they can't use the savings cards. This is because the federal rules that govern Medicare specifically block them from using the tools that other patients have access to. To give you a sense of the scale, roughly 1 in 4 Medicare beneficiaries lives with obesity. That is tens of millions of people affected by these restrictions. And the number of people trying to access GLP-1 medications is growing every year. Lorraine and I understand how real that cost question is personally. Our insurance does not cover obesity medications, and we have paid for every single dose ourselves. So when we talk about the financial pressure of staying on treatment, we are not speaking from the outside. We are right there with you. That's the reality today, and it has not changed. So where is the $50 number coming from? It traces back to a White House press conference in November of 2025. During that announcement, the administration discussed efforts to bring the United States drug prices closer to what other developed countries pay. The approach is called most favored nation pricing, and the idea is relatively straightforward. The United States often pays dramatically more for the same medications than countries like Germany, France, or Japan. Most favored nation pricing would use those lower international prices as a benchmark and push American prices towards that level. As part of that announcement, agreements were made with Eli Lilly and Novo Nordisk, the companies that make Zepbound and Wegovy, to lower prices on several widely used medications. The announcement also referenced a new program being developed by the Centers for the Medicare and Medicaid Services, the federal agency that runs Medicare and Medicaid. We now know that program is called the Balance Model. That is the program people are referring to when they talk about $50 GLP-1 medications. But here's the piece that keeps getting dropped every time this story spread across social media. Every time your favorite YouTuber told you could get $50 GLP-1s. The program has not yet started. The policies required to expand Medicare coverage are not in effect. What is actually happening is that federal policymakers are beginning to test whether expanding access to obesity medications could improve health outcomes and reduce the long-term cost of chronic disease. They are testing, not implementing, not announcing, but simply testing. That distinction matters enormously if you're sitting in the gap right now trying to figure out how to pay for your next prescription. So let's talk about what the Balance Model actually is. Balance stands for Better Approaches to Lifestyle and Nutrition for Comprehensive Health. It is a pilot program created by the CMS Innovation Center, the part of CMS that tests new healthcare payment and coverage models before broader policy changes are considered. The goal is to find out whether expanding access to obesity medications combined with structured lifestyle support can improve long-term health outcomes for people on Medicare and Medicaid, and whether doing so might actually reduce the overall cost of treating the chronic diseases that obesity contributes to. That second part is important because it is the argument that has struggled to gain traction inside federal healthcare policy for years. Covering these medications costs money up front. The question being tested is whether doing so prevents far more expensive problems down the road. Heart disease, diabetes complications, joint replacements, hospitalizations. The argument is that treating obesity now is cheaper than treating everything it causes later. Now, I think you and I can tell them that that's what they're going to discover, but they still have to do the test. Under the model, CMS would negotiate drug pricing and coverage terms directly with pharmaceutical manufacturers. So in this case, Eli Lilly and Novo Nordisk. Those negotiations would address net drug pricing, standardized coverage criteria, and limits on what patients pay out of pocket. The medications included must also meet specific clinical criteria. According to CMS, eligible drugs must be FDA approved for weight management and must demonstrate meaningful effectiveness, including an average weight loss of around 10% in clinical trials. So both Zepbound and Wegovy have met thresholds like this in their trial data, which is why they are expected to be among the medications considered for inclusion. The final confirmed list has not yet been announced. There's also a lifestyle support component. Patients in the program would have access to structured lifestyle programs provided by the manufacturer at no additional cost. Did you catch that? Provided by the manufacturer. They must be designed to help people maintain results over time. CMS has outlined how this would roll out in phases. The first step is a Medicare Bridge demonstration, a separate program that acts as an on-ramp to the broader Balance Model. CMS plans to launch this demonstration in July of 2026. So a lot of people are talking about, it'll be effective. Everybody can get the medications in April or May for $50. That's not going to happen. The demonstration will not launch until July of 2026. This demonstration will operate outside the traditional Medicare Part D structure, meaning CMS administers it directly. Under this program, Medicare beneficiaries who meet the eligibility criteria would be able to access GLP-1 medications with a copay of around $50 per month. So there's your $50. Unfortunately, we still don't know the criteria for eligibility. CMS has said that detailed eligibility criteria, including things like BMI thresholds, related diagnoses, or other clinical requirements, will be released in early 2026. As of today, they have not been released. Those details have not been finalized yet. We do not yet know exactly who will qualify when the demonstration launches. That's a real unknown, and we will cover it as soon as that information becomes available. State Medicaid agencies could begin joining in May of 2026. Medicare Part D plans could begin participating in January 2027. The full testing period runs through December 2031. But there's a critical detail that changes how you should read all of that. None of it turns on automatically. This is not a nationwide switch that flips on and suddenly every Medicare patient has access to $50 GLP-1 medications. Participation is voluntary at every level. Drug manufacturers, so Lilly and Novo, must agree to the negotiated pricing structure. If a manufacturer does not participate, their medication is not included in the program. Medicare Part D plans must also choose whether to participate once the model becomes available to them in 2027. As of now, no Medicare plans have officially opted in. CMS has only recently issued notices of intent and requests for participation. We are still waiting to learn which manufacturers will join and which Medicare plans will sign on. That means even when the program launches, your access will depend on whether your specific Medicare plan has chosen to take part. If your plan is not participating, the program does not apply to you, even if it is running in other parts of the country. Those participation decisions will determine how many people actually gain access and how quickly that access spreads. Now, let's talk for a second about the laws that still stand in the way of all of this. And it's something that often gets lost in the conversation. Even if the balance model launches exactly as planned, the underlying federal law that restricts Medicare coverage has not changed. The main restriction comes from the Medicare Prescription Drug Improvement and Modernization Act of 2003, the law that created the Medicare Part D prescription drug program. When Congress wrote that law, it included a list of drug categories that Medicare plans were simply not permitted to cover. One of those categories was medications prescribed for weight loss. At the time, obesity was widely viewed as a lifestyle issue rather than a chronic metabolic disease. It was viewed honestly as laziness. Weight loss medications were grouped with cosmetic treatments and excluded from coverage. That was over 20 years ago. The science has changed dramatically, the understanding has changed dramatically, but the law has not. This creates a situation that many people find genuinely confusing, certainly I do, and understandably frustrating. The exact same medication, the exact same drug, the same dose may be covered by Medicare if it's prescribed for type 2 diabetes, but not covered if it is prescribed for obesity. The diagnosis written on the prescription changes everything, not the drug, not the dose, the words on the piece of paper. The second barrier is the one that hits people when they try to use the savings card they hear about from friends with commercial insurance. Most pharmaceutical manufacturers offer savings cards. So both Lilly and Novo offer savings cards. They're basically coupons. People with employer insurance or individual plans use these cards regularly and bring their monthly costs down considerably. But if you are on Medicare, you are legally prohibited from using them. That restriction comes from the anti-kickback statute, a federal law designed to prevent companies from offering financial inducements that could influence purchasing decisions within federal healthcare programs. The intent is to prevent fraud and protect programs funded by taxpayers. We understand why the law exists, but the practical result is that you cannot access the same discount that someone with employer insurance can use at the exact same pharmacy counter for the exact same medication on the same day. That's not a hypothetical. That is something people experience every week. Those two restrictions together, no coverage for obesity treatment and no manufacturer savings cards, explain the gap that so many of you are running into right now. There is a bill in Congress that would change this directly. It's called the Treat and Reduce Obesity Act. Most people in this space know it as TROA. I want to be honest with you about this bill because I think you deserve a straight answer. TROA has been introduced in Congress over and over again, going back to 2013. It has bipartisan support. It was introduced again in 2025 in both the House and the Senate, and it has never passed in full. Every time it comes up, it stalls. The main reason is cost. The Congressional Budget Office has consistently found that expanding Medicare coverage for these medications would increase federal spending, and that finding makes it very hard to move in any budget environment, regardless of which party is in control. Last Congress, a narrowed version actually cleared the Ways and Means Committee with votes from both sides, and that was real progress, and it still did not become law. I've been watching this bill for as long as we've been on the journey. I understand why people get hopeful every time it gets reintroduced. I felt that myself. But I also think the most useful thing I can do for you is tell you the truth, which is that this bill has a long history of going nowhere. That does not mean you should ignore it. If anything, the fact that it keeps getting introduced and keeps stalling tells you something about where the pressure needs to go. If you want to do something concrete right now, contacting your representatives about TROA is a real action you can take. While this process plays out, you are not entirely without options. They are not the solution you are waiting for, but they are worth knowing about. The first thing worth discussing with your doctor is whether you have a related diagnosis that is already covered. GLP-1 medications are widely covered for Medicare when they are prescribed for type 2 diabetes. If you have a diabetes diagnosis or are at elevated risk, that is a conversation worth having directly with your doctor. Not every patient qualifies, but many people do not realize this pathway exists until someone points it out. The second option some people explore is manufacturer patient assistance programs. Novo actually has one. These are entirely separate from the savings card that Medicare patients cannot use. Some pharmaceutical companies offer income-based assistance programs for patients who meet certain financial criteria. These programs have their own eligibility requirements, they are not guaranteed, and they can take persistence to navigate. But they are a legitimate option, worth asking about directly with the manufacturer, not the pharmacy, the manufacturer itself. The third pathway, of course, is the cash pay program. So both Lilly and Novo have cash pay programs. Several companies now offer GLP-1 prescriptions and ongoing care through monthly telehealth programs, flat fee models that are outside of the insurance programs. Costs vary widely and the quality of clinical oversight varies too, so research matters here. But for some people, this has been the most accessible path while waiting for the coverage landscape to change. Lorraine and I have looked into most of these options ourselves, and as you know, we have used a telehealth provider, Mochi Health, and used compounding drugs, but it's paying cash. So really the cash options are go through NovoCare, Lilly Direct, pay cash, which is usually lowered to around $4.99 at the highest doses, or going through a telehealth and using compounding. So what does all of this actually mean if you're on Medicare right now? The rules have not changed. Medicare still generally does not cover these medications for obesity. You still cannot use manufacturer savings cards. The costs are real and they have not been resolved. What has changed is the direction of the conversation. And for the first time in a long time, that direction does feel meaningful. For years, the argument that obesity should be treated as a disease inside federal healthcare policy struggled to gain any real traction. What is happening now, the balance model, the bridge demonstration, the White House announcement, the conversations happening in Washington represents a genuine shift in how seriously policymakers are taking that argument. The bridge demonstration is scheduled to launch in July 2026. The broader balance rollout for Medicare plans would follow in 2027. Even then, access will depend on which manufacturers and plans choose to participate. Eligibility criteria will determine who qualifies. It will not arrive everywhere at once. So if someone tells you Medicare patients are getting $50 GLP-1 medications next month, that is not accurate. And if someone tells you nothing is changing and this conversation does not matter, that is not accurate either. Something is moving. It is moving through a process, and that process takes time. For the people caught in the gap right now, that's the hard thing to hear. We know that. We live a version of it ourselves. That is not fair. And we think it is worth saying out loud. what we can do is make sure you have accurate information so that you can make the best decisions possible while the system catches up. If this video helped clarify what is actually happening, please take a moment to like and subscribe to the Downsized. We publish new videos every day to help people better understand GLP-1 medications, obesity science, and how to navigate treatment in the real world. And I want to hear from you. Are you on Medicare and trying to access GLP-1s right now? Have you run into the savings card issue? Have you found something that has worked for you? Please leave a comment below. Your stories help us understand what people are actually facing and how they help other people in the same situation know that they are not alone. My name is Christopher Durham, and we are the Downsized.